Okay, good afternoon, everybody. Glad to see you all here. It gives me great pleasure this afternoon to introduce to you Dr. Bruce Lee. Dr. Lee received his undergraduate and his medical degree from Harvard and received an MBA from Stanford. He's been a professor here at the CUNY School of Public Health, professor of health policy and management since 2019. He's the executive director of the Center for Advanced Technology and Communication in Health, CATCH, here at the School of Public Health. Since 2007, he has been the executive director and founder of Public Health Computational and Operations Research. He has published over 245 scholarly articles and counting, and his paper on COVID vaccine efficacy won the Article of the Year award from the American Journal of Preventive Medicine in 2020. His computational work has also appeared in the New York Times, and he is regularly published in the press. He recently received a multi-million-dollar in conjunction with Columbia with the New York City Department of Health and Mental Hygiene, which he will tell you about today. Bruce, thank you so much for being with us today and talking with us about computer modeling in response to the COVID-19 pandemic.
All right, thank you, Betsy. Thank you for the kind introduction, and happy to go through some of our modeling activities and talk a little bit about the COVID-19 pandemic. So with that, I will hopefully, can everyone see the screen?
Yeah.
To say how computer modeling has helped the response to the COVID-19 pandemic. So just to start off, I wanted to acknowledge, I'm going to be mentioning a number of studies here, and they've been supported by a range of different sponsors ranging from the NIH to CDC to the Bill and Melinda Gates Foundation. I also want to point out the dean here at the School of Public Health also offered us funds earlier in 2020 to help jumpstart a lot of our COVID-19 modeling. So we very much appreciate that. So this has all helped really move our modeling work forward. So why do modeling? So one of the big issues is many factors and processes can really affect infectious disease spread. It's really quite a complex system. So if you look at the spread of infectious diseases, it follows many different types of patterns. So it follows biological patterns, it follows social patterns, like how people mix with each other and interact with each other. It affects economic patterns. So people who are less able to seek healthcare or have less access to healthcare may be more likely to suffer worse consequences. People who are in higher density locations and aren't able to socially distance from one another may be more susceptible to infectious diseases. So we have to keep in mind that even though that there is a pathogen, even though that there is a virus, there are many different factors in society that really affect the spread. So these are quite complex. So it may be easy to sort of say, okay, there's a cause and effect with certain situations, but with infectious diseases, it can get quite complex. And then on top of that, as you've probably noticed over the past year and a half, there are many different types of interventions that need to be taken not in isolation, but in combination. And each of these different types of interventions, whether it's trying to keep physically apart, whether it's wearing face masks, whether it's testing, vaccination, treatment, all have different factors and characteristics and work across multiple different levels. So again, very complex systems. So how do you bring all these different things together? And we also have to keep in mind that the impact of not only the pathogen and the resulting disease, but also interventions can be quite complex and far-reaching. So it's not a simple matter of just doing something and immediately seeing the result. A lot of these results and consequences are subtle and happen over time and can be quite dynamic. So once again, a very, very complex system. So how do we actually account for all these complex systems and address them? And how do we actually come up with the right solutions? So as you know, as human beings, we can figure out something that happens immediately. So if you push a chair, the chair moves, or you paint a wall, the wall has changed color. But with many health interventions and many disease processes, it's more complex than that. You have secondary, tertiary, direct and indirect effects. So as human beings, we struggle to say, okay, wait, how do we connect all these different types of things? Computational approaches, computational modeling, really can help organize this complexity so that we can all see the complex system ourselves. And it also helps communicate your conceptualization of the system. So for instance, if I think something's connected in a certain way and someone else thinks things are connected in a certain way, we can look at the model and our modeling of the system and then compare and contrast what the differences might be. It also helps us understand our conceptualization of the system as well, because many times when you don't have that representation, you don't even know what you're thinking as well. So computational modeling can be very helpful. Now, one thing I want to one clear distinction that I want to make is you've probably heard the word modeling tossed around a lot over the past year and a half. And we know that it can range in great degree. Of course, there's the fashion modeling, which is not the type of modeling that I do. You can tell based on my distinct lack of fashion sense. But there's, you can build like airplane models, you can build, so there's a wide range of different types of modeling. So I want to point out a clear distinction between the different types of mathematical and computational models that are out there. So one type is what we call top-down approaches. So this tends to be statistical modeling, where you get a bunch of data and you maybe hover above the data and you look for patterns. So there are many techniques, as many of you are probably familiar with, to do this, but in general, you're basically starting with the data and you say, what are the patterns that we see? This can be helpful to identify associations, correlations, or help us get a better sense of, okay, maybe this is something where we need to delve deeper into. But it's not very good at establishing cause and effect, because again, these are more associations and generalizations. And also sometimes you might miss some of the details. So this type of modeling is quite helpful. So when you heard some of that modeling early on in the pandemic, like for instance, the prediction that there's going to be X million deaths over the next year or so, a lot of that was based on the statistical top-down modeling. The second general type of modeling is bottoms-up approaches. This is where you try to recreate what's going on. So you recreate the mechanisms and processes, and you actually try to simulate what's happening. And this is bottoms-up systems modeling, where you try to recreate a person, you try to recreate a healthcare facility, a school, a town, a region, a country, or what have you. This is more mechanism focused, so you actually want to know the cause and effects of each of the different processes. And whereas the first top-down approach is more useful for discovery and figuring out, okay, where should we focus our time and energy, this can be helpful in terms of testing what might happen under different types of circumstances, forecasting what might be going on, or testing different types of interventions and policies. And the type of modeling that I'm going to be talking about here is more this bottoms up. The systems modeling is what we do. Now, there's a number of dangers in not using a systems approach, meaning not really understanding how these complex systems work. So one is coming up with band-aids rather than sustainable solutions. And we've seen this many times before the pandemic and also during the pandemic, where people think, okay, let's do a quick stopgap measure, but there's no real longer term planning or strategy. We saw that at the very beginning of the pandemic, where we said, okay, we've got to put a stop on things. We've got to quote, flatten the curve. And so that's when you saw some of the closures, because we were in a situation where we had to hustle, because if we didn't put a stop on things, put a break on things, then the death would continue to exponentially rise. The hospitalizations would continue to exponentially rise. But that was not a sustainable solution, as we knew at the time. It was more like, let's put a pause and let's figure out the sustainable solutions. A third issue is missing secondary and tertiary effects. And this can be both negative effects, like unintended consequences, and this can also be positive effects. So an example of missing the positive effects is people may not see the longer term downstream effects of wearing face masks, for instance. So people might say, okay, well, immediately it's an annoyance, it's bothering my face. I'd rather not wear a face mask. But people may not realize, well, downstream, there are a lot of benefits in terms of wearing face masks. So that's an example. And of course, there's unintended consequences of doing things. So for instance, there's unintended consequences of not taking action, not using things like social distancing and face mask use. I mean, you may not immediately see that, but that might take 1 month or several months or a year or several years to really manifest themselves. And finally, there's a cost of trial and error. And we've seen this during the pandemic as well. If you don't have an organized plan and you just try different things, you'll end up costing time, effort, and resources. So it's really helpful to really understand the system and the reverberating effects. And how are you going to do that? Well, you can't really do it in real life, because if you do it in real life, you ultimately are stuck with the impact. So computer modeling, simulation modeling can really help with that. So that's essentially the things that we do. So I want to emphasize that we've been doing this for a number of years. So for the past 15 years, we've been steeped in the pandemic preparedness and response community. And not just pandemic preparedness and response, but really looking at the control of infectious diseases in general. And this timeline shows some of the key milestones in our work. So I've been part of something called the MIDAS Network since 2007, an investigator with the MIDAS Network. And MIDAS stands for Models of Infectious Disease Agent Study. And it's an NIH-sponsored network where it's always been a group of investigators around the country, in some cases in different parts of the world, that do different types of infectious disease modeling approaches. And whenever there is a major infectious disease threat to the United States, one of our responsibilities is to be ready to help with the local, regional, national, and potentially global response. So this happened in 2009 when the H1n1 flu pandemic came upon us. So if you will recall, back in the spring of 2009, that's when we first started hearing about this novel flu virus that emerged in different parts of Mexico. And then it started spreading throughout the world to the United States and other places. So already during the spring of 2009, we were involved in helping with a lot of the response. And eventually, our team was embedded in Health and Human Services. So we were working with the ASPR, the Health and Human Services in general, the Department of Homeland Security, and CDC to run our computer models to help with the national response. And I'm going to show some of the studies that emerged from that, just to give us a sense of what we've done with that. We've also done work with the control of healthcare-associated infections, like the spread of MRSA, CRE, and all those other types of nasty bugs that are antibiotic resistant. We've helped with the Ebola response. We've helped inform Congress during the Zika outbreak, and ultimately during the COVID-19 pandemic, we've been very active. So we've been doing this for a while. So let me give you some examples of some of the work that we've done. So during the 2009 H1n1 pandemic, while we were embedded in Health and Human Services, we had a situation where not all the vaccines were readily available. So if you recall, back in the spring of 2009, the H1n1 flu virus was isolated, and then they got started in manufacturing the vaccine. And back then, the standard flu vaccine took 4 to 6 months to really grow in egg culture. So even though the pathogen was identified back then, it wasn't until half a year later that the vaccines would become available. And even with that, there were numerous manufacturing delays. So while we were embedded in Health and Human Services, they would frequently come to us and say, okay, this is the manufacturing schedule as we know it. This is when vaccines will be available. And what we would do is we would run our computer models to say, okay, this is the impact of doing those types of distributing vaccines in different ways. And especially since they had a limited number of vaccines, one of the key questions is, where should that limited number of vaccines go to first? Which communities should receive them? Which individuals should be vaccinated? And this is an example, and it was published in Health Affairs, ultimately, of a study that we ran. And so what we did is we said, okay, what happens if we have a limited number of vaccines and it goes to different people, different populations, different neighborhoods? And we found that the best neighborhoods to target initially would be low-income neighborhoods. And so the reason for that is if you look at lower income neighborhoods, the population density tends to be a lot higher. And people in lower income neighborhoods frequently travel to higher income neighborhoods and other neighborhoods for work or school. And the reverse doesn't tend to happen as often. So you don't tend to have people in higher income neighborhoods traveling to lower income neighborhoods. So it ultimately makes sense to try to protect lower income communities first before any other communities. And I don't have the results on the slide, but you can clearly show that if you give it to lower income neighborhoods, you have better overall control of the pandemic. And this is an example of what we describe as utilitarian approaches leading to having altruistic benefits, meaning that we know that it's important to protect the most disadvantaged in society first. That's the right thing to do. That's the good thing to do. But it's also the best thing to do for all of society, showing that, okay, if you're protecting the most disadvantaged economically, you're actually helping everyone else. You're reducing the overall number of cases. You're reducing the overall number of deaths. You are reducing the amount of costs. So we felt that this was important, and this really showed that when you're talking about, you talk about, on the one hand, social justice, on the other hand, okay, doing what's most effective, and many times those actually are one and the same thing. That you really want to protect people who are most disadvantaged in society. We also addressed, and this is a question that came up very early on in the pandemic, and people didn't realize that these things were being considered back in 2009. So one of the first things that was considered by the CDC and different agencies within the government in the spring of 2009 was, should we start doing social distancing? Should we start closing schools to prevent the spread of the virus? And the reason why most people didn't hear about social distancing until 2020 is because we ran the scenarios, we looked at what the impact might be closing schools, and we found that it would not be effective enough in controlling the virus, especially since the vaccine will be available in 4 to 6 months, and it will be extremely costly. We also calculate the costs of closing schools. So as a result, CDC and the federal government decided not to tell everyone you should consider closing schools. And it wasn't until 10 years later that people start becoming more familiar with the terms like social distancing. But this is something that's been considered for many years. And the pandemic preparedness and response community was well aware of these different types of methods and approaches. And we knew when these should be done and when these should not be done. So this is the paper looking at really the cost of school closures, and we found it's tremendous. And as we found that, when you do close schools, there you lose a lot of productivity costs, there are caregiver costs, and all these different types of things. So I want to emphasize that a lot of the evidence base for handling pandemics, handling infectious disease outbreaks in general, has already been there for many years. And one of the challenges during the 2020 pandemic was, how do we get a lot of this evidence base out there? Because as you know, there's a lot of noise. There's a lot of people spreading different types of information, including misinformation, disinformation. So that was one of the challenges early on during the 2020 pandemic. We also showed like the impact of vaccinating different groups, like the workforce in different ways, like what happens if you vaccinate the healthcare workforce, or different employees, et cetera. So again, a lot of this established precedents within the scientific literature on how to handle a pandemic. So moving right along, so okay, we also looked at other things such as I mentioned, we were involved in the Ebola outbreak response. So this is an example study that we did looking at the cost of an Ebola case, and then we were also involved in the Zika outbreak. So one of the key questions early on during the Zika outbreak was, okay, how much should be allocated by Congress to bolster the Zika response, prevention and control. If we recall back then in the mid-2010s, President Obama had proposed a certain budget to Congress, and Congress was debating about that. So then we got requests from Congress, different congressional members, to help them better understand the potential impact of Zika and what the return on investment would be when it comes to different levels of investment into the Zika response. So this is an example of where we basically created a model of the United States and found that in some of these states that were highly susceptible to Zika, the spread of Zika, you know, what their costs would be. And we found that the costs far outweighed the investment that was proposed. We've also since then been doing work on guiding the development of Zika vaccines. So while, you know, a lot of the general public may have forgotten about Zika, it's really, you know, concerns about Zika have continued. So there have been a number of different Zika vaccine development activities, but we have developed and run models to help guide those activities, meaning that, okay, what should a Zika vaccine look like? You know, how many doses should it be? How long should the protection last? What kind of efficacy targets will be needed? So this has been continuing. And this is something that everyone should keep in mind. Just because a vaccine disappears and a disease disappears from public consciousness, there are still activities moving along to try to develop vaccines and other interventions, and we need to continue guiding those things. We were very fortunate, quote unquote fortunate, that the SARS outbreak happened, you know, early 2002, 2003. Now, I don't want to say we're fortunate that it happened, because of course, you know, there are people who suffered from the outbreak, but learnings from that actually helped stimulate vaccine development efforts and those types of things. So all that ultimately made it more likely that we would have those interventions come 2020. So all of this is actually connected. And we should think about pandemics and think about outbreaks, not just while they're happening, but in between those years. Like how do we keep things going between those years so that we aren't caught in a tough situation once an outbreak or an epidemic actually occurs? Another thing that we've looked at over the years has been different types of medical product and vaccine distribution methods. So we developed, with funding from the Gates Foundation, we developed a simulation platform called Hermes, where you essentially can take any type of supply chain, any type of distribution system, and create a computer model of it. So we've created computer models of, and that computer model can then serve as a virtual laboratory or a testing device where you can test changes in the distribution system, or what happens if circumstances change, what happens if weather gets worse, what happens if you have a new product, what happens if the population shifts around. So again, this serves as a virtual laboratory to test these different things. And we've used our computer modeling, our Hermes computer modeling, to help different countries improve and in many cases redesign their vaccine supply chain. So for instance, we worked with the Republic of Benin and their Ministry of Health to completely redesign their supply chain. And this in turn, and this work occurred, you know, over the past decade, and this in turn has put them in a better situation when it comes to distributing the COVID-19 vaccine and other types of vaccines. So we've done different types of work. And this is just a timeline on how we work with the Benin Ministry of Health, as well as UNICEF, the WHO, World Health Organization, the Gates Foundation, and Gavi to really redesign their vaccine supply chain. So essentially, we used a model to represent their supply chain, ran the model, and found all the different types of bottlenecks and shortcomings. And then we discussed with them, okay, what are the different types of redesign options? And then we ran simulations of those redesign options, and we found that there was one redesign option that was clearly better than the rest. It basically would allow more vaccines to be delivered and at the same time be less costly. So this is sort of the holy grail. You want to be more effective and also less costly. And the Republic of Benin says, okay, that sounds good. And then basically, along with a number of NGOs, the WHO, Gavi, and Gates Foundation, and UNICEF, they've redesigned their supply chain based on our recommendations. And we showed, how the new redesign could save significant costs. And then we've also shown situations where coping can hide deeper systems problems. So for instance, we did a study where we evaluated the supply chain of Bihar, India. So we developed a computer representation of the entire supply chain. And we found that there are many situations that very well-meaning health professionals would compensate for deficiencies in the system. So for instance, if there weren't enough motorbikes, if there weren't enough trucks transporting vaccines, they themselves would grab a bunch of vaccines, jump on a bus, or jump on a horse, or all different types of animals, and then carry the vaccines themselves. And they thought they were helping. But in turn, they were hiding many of the systems problems that existed. So if those systems problems weren't fixed, if you have a surge where you then introduce like all these COVID-19 vaccines, then those healthcare workers will no longer be able to cope and the whole system breaks apart. And we saw this during the pandemic, where a lot of healthcare professionals were sort of coping even before the pandemic. They were doing a lot of stopgap measures. They were using just enough PPE that was available, and things seemed okay. But then you throw in a stressor like the pandemic and you increase demand, then suddenly things start to break down. So this is an example of work that we did prior, but then became very relevant during the pandemic to show that there's problems with coping and covering up a lot of these issues. And then we've also used Hermes to look at things such as using drones to transport vaccines. So this is just an example of the work that we did prior. And again, I mentioned this because you can't just jump right into the pandemic and start doing work. And also, you have to have a runway. And on top of that, we generated a lot of the evidence base that was then subsequently used for the pandemic. Was it used ideally, or was it used thoroughly or completely? No, but we did see some of the principles that our Midas network, us and the Midas network really generated to help inform policymakers throughout the world. Okay, so with that, one of the key things we found over the past 15 years was the importance of vaccine distribution and planning. How do you get vaccines out there? And during the pandemic, this was around summer of 2020, I wrote this article for STAT as a warning, and basically saying that, okay, you can talk about vaccines being developed and you can talk about funding them, but where's the talk about how they're going to be distributed? Where's the talk about setting up the supply chain? This is not a trivial operation. This is very complex. And we really tried to push this throughout 2020 and said, you've got to be ready, you've got to be ready, you've got to be ready. And one of the unfortunate things that happened is at the end of 2020, many states weren't ready, and the supply chains weren't really in place. And so ultimately they were, things were rerouted and fixed in 2021 to some degree, but this really stressed the importance of planning ahead. The vaccines don't magically get to people. They don't suddenly just appear in people's arms. They have to get there, and the journey really matters, because you can have the perfect intervention, you can have the perfect vaccine. There's no such thing as a perfect vaccine, but you can have the perfect product, no such thing as a perfect product. But even if they are, and they don't get to the people, then they're pretty much useless. So we have to keep in mind things like distribution systems, and administration systems and things like that. Okay, so that brings up to 2020. So with that in mind, we had a long on-ramp in terms of information and learnings and knowledge, and then the pandemic hit. So So we've done a lot of different types of work with the pandemic, and our work has received a fair amount of coverage in the media. This is just some examples of some of those headlines. So one of the things that we wanted to do really early on was determine the impact of the pandemic. So if we recall, around February or March, when people start talking about interventions, talking about, okay, we have to start being careful. And then there was a lot of talk about, oh, but this is going to cost a lot of money. It's going to cost a lot of money having these precautions in place. And so there were people saying, oh, we shouldn't do these things because it costs a lot of money. But we felt that that was a one-sided argument because, well, to determine whether something will be helpful from an economic standpoint, you have to know the impact of not doing anything or allowing the virus to spread. Or even if you do try to prevent the virus from spreading, what happens if it spreads to different degrees? What might be the impact? So what we did is, and the study was published in Health Affairs, we created a model of the entire United States, and we represented each person in the United States. And we said, okay, let's simulate the spread of the virus throughout the US population and see under different scenarios what might happen. And each person, each computational person, if he or she got infected, then that person then would have a probability of being symptomatic versus asymptomatic. And if the person is symptomatic, that person might develop mild COVID-19 and just require some over-the-counter medications, or more severe, or get hospitalized. So we built into all these different possible outcomes. So just like a real person, that person could have different possibilities. And then each of those things was associated with clinical outcomes as well as costs. So for instance, if you just take over-the-counter medications, that's all the cost. If you're missing a few days of work, that's your cost and productivity. If you have to be hospitalized, there's the cost of hospitalization or being on the ventilator and all these different types of things. And of course, if unfortunately you don't survive, then there's that cost to society as well. And we found that the costs are pretty significant. So you can see on this slide, on the x-axis, the percentage of the US population that ends up getting infected with the SARS-CoV-2 virus. And then the y-axis are the resulting costs. And you can see those quickly go into the billions and even the trillions of dollars as the virus spreads further and further. And so, we really broke this down into things such, what are the hospital costs, what are the medication costs. And the other thing we did is we looked at what's the difference if you just account for the immediate acute costs, meaning just the hospital stay or just the 2 weeks that you're sick. And then what happens if we add on a year after that? Like what about continuing costs? Like what happens if you have long COVID, or what happens if you have continuing breathing problems or fatigue after recovering from COVID-19? And another thing that we showed is those costs are quite significant as well, and it can push it even further. So this was a way of quantifying the impact. And so this really helped people understand the impact of the virus, and then how to really balance the costs of different types of interventions with that impact. So another thing that we did early on, and this was work that we were doing, we started in spring of 2020 and finished in late spring 2020, early summer 2020. And this was providing guidance on what COVID-19 vaccines should look like. So if you recall early on, there was talk about developing COVID-19 vaccines. The FDA came out with the guidance that the vaccine should be at least 50% effective, so have an efficacy of at least 50%. But we felt that wasn't enough. We developers and policymakers needed more guidance, because 51% effective is not the same as 90% effective or 80% or 70%. Plus, there's the thinking, okay, how long should these vaccine protection work, and how many people need to be covered? How many people need to get the vaccine? Because we knew that given prior experience, you can't expect 100% of people to get the vaccine. And in fact, there'll be many people who are vaccine hesitant or want to wait longer. So we further developed our model of the United States, And then we simulated what would happen if different proportions of the population got vaccinated in different ways with different types of vaccines. And this ultimately was published in the American Journal of Preventive Medicine. And this helped us determine that vaccines had to have an efficacy of at least 70%, 70% efficacy, and there had to be 75% coverage to prevent an epidemic. So in other words, these are the people, like if you cover this many people with this efficacy vaccine that's greater than 70%, then you can prevent an epidemic. And this was useful for countries that didn't really have SARS-CoV-2 yet at the time. So if you recall, back in summer 2020, there were countries like New Zealand, Taiwan, Australia that had relatively few cases because they were able to control the virus fairly well, certainly much better than the United States. So they would have a situation where they would need to know how good does the vaccine need to be and how many people need to be covered. So that's why we ran these scenarios. Now, the United States was in a different situation at the time. The virus was already spreading. So the question for the United States was different. So now that we have an epidemic or a pandemic, and the virus is spreading widely, how good does the vaccine need to be, and how many people need to get the vaccine for us to, quote unquote, return to normal? Meaning, at what point can you actually remove all these other social distancing measures? And we found that the efficacy target was higher. It had to be at least 80% or greater. And the coverage target was higher. It had to be at least 75% or greater. Below that doesn't mean the vaccine is useless, still can be helpful, but we have to shift our expectations. The vaccine alone isn't enough to have us immediately to return to normal. And so if you compare what we found with what subsequently has happened, we've seen this situation. We haven't reached 75% coverage. And so the pandemic has continued and virus has continued to spread. So we really can't remove those other measures. And on top of that, with spread of the Delta variant and other changes, it looks like the vaccine effectiveness has gone down from initial 90% or so. So this continues to guide what we can do. The New York Times, seeing this, was interested in adapting our base model, or a simplified version of our model, into an interactive tool. And this was published in the New York Times, and they basically use this to show, okay, here are the different types of scenarios or situations where we can actually reach herd immunity thresholds, meaning a high enough percentage of the population has either been infected and recovered from the virus or been vaccinated and thus protected for virus transmission to be interrupted to the point where we can start returning to normal. So if you want to go onto New York Times, there's this interactive tool where you can try different types of scenarios and see how long that might take. So, so that's still up there. Another question early on in the pandemic was, well, what about medications? So if you recall, early on in the pandemic, people were talking about different medications like hydroxychloroquine and azithromycin, and other possibilities, remdesivir. And we wanted to see, okay, well, what happens if you do develop a medication? What's the value of that? How is that going to help, not just individually, but also population-wise, pandemic-wise? Because one of the things that we looked at back in 2009 is the impact of using something like Tamiflu or Relenza, which are antivirals, flu antivirals. How would that control the pandemic back in 2009? Because before vaccines were available, that was the only thing that was really available when it comes to pharmaceutical interventions. So we knew that that was the thinking, again, with the 2020 pandemic. So what happens if you do find a medication that can, say, reduce the infectious period by half a day or 1 day or 2 days or what have you? So we used our model to run all these different scenarios. And we found that even if you reduce the infectious period by like a half day or a day, seemingly not too long, it can still have a big impact in terms of reducing the number of cases and saving billions of costs. So that showed the value, the potential value of something like remdesivir. Of course, we've subsequently seen that medications like hydroxychloroquine and azithromycin, it didn't seem like they had an effect on the infectious period or recovery from the virus. But this is still out there. So meaning that if you have medications that can reduce the infectious period, it can have tremendous value. That might be applicable to this new Merck medication that they are planning to apply for emergency use authorization for. So developing treatments is still an important factor in terms of controlling the virus. And this just shows that you can potentially avert 1.4 to 30 million cases if you reduce the infectious period by half to 3.5 days. And this essentially shows how that changes. Of course, naturally, the greater number of days that you reduce the infectious period, the greater savings and the more cases that you can avert. And then this shows what happens if you you reduce the infectious period by 3.5 days, and that works for 75% of the COVID-19 cases. Again, we're talking about billions of dollars of cases, billions of dollars of cost savings. So it's a pretty significant savings. Another big issue was early on during the pandemic was the shortage of personal protective equipment like face masks and specifically N95 masks. So there's N95 respirators. And one of the missteps that happened across our healthcare system was that a lot of hospitals really cut down their supply of PPE, cut down their supply of face masks prior to the pandemic. Because in many cases, they viewed that as a cost. Like, oh, we have all these face masks sitting around being unused. Why do we have to continue to have all these face masks around? Because they cost money and you can't keep them forever. But that reduction or those cost-cutting activities ending up costing our society a significant amount. And when we're talking about a significant amount, we're talking about not only costs, but also lives. So that was a big mistake going forward. And so there was a lot of scrambling in the spring of 2020 to try to get more of these face masks to really hustle the push the manufacturing of these. And we felt even at that time, there wasn't enough work really to determine, well, how many face masks are really needed? How many N95 respirators are really needed? So we constructed models of different healthcare facilities and their personnel to come up with estimates on, throughout the pandemic, how many N95 respirators would be needed. And this was published in Infection Control and Hospital Epidemiology. And we looked at the impact of changing different circumstances, like what happens if the virus becomes more transmissible or more contagious, or what happens if people have to see more patients and thus have to use more face masks. This just shows some of the results from that. And we showed that like a single acute care hospital would require 400 to more than 100,000 N95 respirators per month for COVID-19. And this graph basically just shows how that varies depending on the number of respirators a given healthcare professional will need, and the reuse. In other words, technically these respirators should be use it once and you discard, but then people started using it 5 times and discard, but that's up to the manufacturer limit. And then we got to really tough situation where people were using these masks far beyond the recommended limit, like every single day for 30 days straight, 60 days straight, or what have you. So we looked at all those different scenarios, and naturally we made these recommendations based on the manufacturer's recommendations. In other words, don't use these respirators more than 5 times, or plus or minus depending on the manufacturer recommendations. Another example of work that we did, and this came a little later in 2020, when vaccines were about to be rolled out, we started looking at, okay, now that the vaccines are available and we have an idea of what they look like, what's the value of increasing vaccination coverage, first of all, because there was a lot of talk of, okay, we're starting at 0, and we want to reach herd immunity thresholds. So we want to get 70, if you recall, 70 to 80% of the population vaccinated. It seemed like this binary thing where we either do it or we don't. And there was actually talk on social media and a lot of conspiracy theories flowing around there saying, okay, we'll never reach herd immunity thresholds, so why even bother? And we felt that that was the wrong dialogue, that was the wrong narrative. And we wanted to show that, look, every single incremental increase, you're going to have a certain amount of value. So what we did is we used our US model to simulate different levels of coverages and show that increase. And that also can help inform what's the economic value, and therefore you can invest that amount of money to getting the coverage up and still break even. So say you show that you can save X millions of dollars by increasing coverage from 50 to 55%. Well, that means you can invest that amount of money to increase that coverage and still break even. Or you can invest less than that money and still actually come out net positive. So that was the reason why we conducted this study. The other question was, there were vaccines out there with differing efficacies, especially the reported efficacy for the Johnson & Johnson vaccine was different from the reported efficacy of the Pfizer and Moderna vaccines. So we also wanted to look at what's the impact of taking one versus the other vaccine or waiting for another vaccine or what have you. So that being said, we found that there was no situation in which waiting for a higher efficacy vaccine would result in fewer cases and cost savings and those type of things. Meaning that, okay, if you had a situation where you had vaccine A that had 90% efficacy or effectiveness, and you have vaccine B that had 70% efficacy or effectiveness, and there wasn't enough A available and B was available, you should go for B, because you shouldn't wait, because in the meantime, you continue to be at risk for contracting the virus, and more people are being infected. And remember, the epidemic curve is not a straight line. The longer you wait, the more things go up. So that's what we found with this. So we range, the different levels of efficacy, as you can see on this figure, and we looked at the impact in which, how it would impact, cases, hospitalization, deaths, and all those different types of things. So ultimately, what you want to do is you want to choose the first vaccine available. And I wrote an op-ed for the New York Times summarizing these results and really emphasizing that, at the time, if we're faced with the Moderna versus Pfizer versus the J&J vaccine, get the first available. You want to be protected. And another thing to keep in mind is that these efficacy and effectiveness numbers are not like concrete. They're not set in stone. They're based on looking at populations or groups of people and comparing the vaccinated versus the unvaccinated. And there are a lot of different factors that affect, and then just determining, okay, what proportion of people who are vaccinated got infected? What proportion of the people who were unvaccinated got COVID-19, and comparing that. And that's how you determine effectiveness or efficacy. Well, as you know, there's so many other factors that might affect that. Certain people may be taking more precautions. And especially when a lot of these things were measured, they were measured when people were social distancing and wearing more face masks and things like that. So it's not surprising if the efficacy or effectiveness drops for each of these different vaccines. So there's a tendency to take these things as mantras, as something that's fixed in stone. This has this efficacy, this has this effectiveness, where there's probably more likely a range. So again, choose the first vaccine available is the ultimate lesson with this. And then we also, again, looked at the impact of increasing vaccination coverage by different amounts. This was published in the Journal of Infectious Diseases. And we showed that even a 1% increase in vaccination coverage could avert millions of cases and thousands of deaths. We're just talking about 1%. And that's not a huge amount in terms of increasing vaccination coverage. So this provides further evidence that's important to do, the important work that many of our CUNY SPH colleagues are doing, like Scott Radson and Chris Palmetto, looking at how do we communicate, how do we get people who are vaccine hesitant or not, or vaccine inaccessible. How do we get them vaccinated? Or work that Dennis Nash is doing, helping understand the different populations and the spread of the COVID-19 virus, et cetera. So this provides additional evidence of the importance of all those different types of work and really, the value of increasing vaccination coverage. And we found that coverage increases or cost savings between coverage of 0 to 70% and cost effective between coverage of 70 to 90%, meaning that for every 1% or so increase in vaccination coverage between 0 and 70%, you're actually not only saving lives and preventing hospitalizations and all those things, you're actually saving costs. So it's a net positive thing. You're actually making money. And again, as I mentioned, if you're making money and you're preventing bad health effects, that's a no-brainer. You should do it. You should just push it and do it. And there's actually, since there's cost savings, there's room to pay for these programs that will increase vaccination coverage. And then after 70%, it becomes cost effective, meaning that you do have to invest some money to increase coverage because you are seeing the great gains that you had between 0 and 70%, but they're still gains. So that's basically what we mean by that. And this basically shows the impact on total direct medical costs and total productivity losses and those things. So, throughout the pandemic, I've also done a fair amount of writing and communication. So I've covered COVID-19 for Forbes. It was very interesting at the beginning of the pandemic. It was all hands on deck. I remember, the editors of Forbes were saying, okay, we've got so much things to cover. Who wants to cover this? Who wants to cover that? Because we really had to get the information out there. And so this has been a continuing interesting journey because we've seen so much misinformation and disinformation out there. So ranging from people claiming that the vaccines are injecting sort of 5G chips into you to vaccines are this mass depopulation attempt to things like the vaccines will make keys stick to your forehead and to your body. If that's happened to anyone, let me know, but I haven't seen anyone who's become like Magneto after the vaccination. But it's been quite incredible. So if you're on social media or if you're following the news and those things like that, you'll see literally every single day there's a new conspiracy theory emerging. And that's really caused a lot of confusion among the general public and also among decision makers and policymakers. There's been a lot of inconsistency out there in communication. So communication is a really important thing. And so really, it's a bedrock of any type of public health policy making or intervention. You can't just implement something without having a proper communication strategy. And that strategy has to come way before the intervention actually occurs. So, we want to emphasize that importance. And that really fits into this slide. And as Dr. Eastwood mentioned, we, as a partnership with Columbia University, have been awarded the New York City Pandemic Response Institute. So this is basically seed funding to establish a Pandemic Response Institute that will work closely with the New York City government, as well as a number of different key stakeholders throughout the city to find better ways to respond to the current pandemic, because it's still going on, but also prepare the city and our population for future pandemics, future outbreaks, and also future emergencies in general. We have to keep in mind that preparing for a pandemic has heavy crossover with preparing for other types of emergencies as well. And so, for instance, with this Pandemic Response Institute, members of our CUNY SPH faculty will be leading efforts, leading different cores in communication. So, I previously mentioned Chris Palmetto and Scott Radson will be key faculty members in terms of advancing our communication efforts for the Institute. Community engagement, Diana Romero and Deborah Levine are going to be spearheading efforts in terms of community engagement. So community engagement is really important. because you don't want to be in a situation where people feel like they're being ordered to do something without understanding the rationale, because there's scientific rationale behind all these things, behind vaccination, behind face mask use, et cetera. So we really want to really shift the paradigm and say, this should be a situation where you really understand the needs and the concerns and the issues of different communities, including communities of color, disadvantaged communities, et cetera, because they're really the bedrock. And we've shown in our previous studies that it's really important to control the spread of any virus within different diverse communities and disadvantaged communities first. And finding ways where people can feel like they're part of the decision making and they're actually making decisions for themselves. And then we've got workforce development that Ashish Joshi is going to be spearheading. And that's like, how do you develop the next generation of workforce that will be prepared to help dealing with pandemic preparedness and response, as well as emergency response in general. So this is very exciting. And then we also have other activities going on. We'll have other activities for the Pandemic Response Institute. Elizabeth Kelvin will be doing work in data science. And of course, she's done a tremendous amount of work in epidemiology. And then we'll also be doing modeling work as well. But we shouldn't let these different initiatives limit ourselves, because there will be other types of pandemic response and preparedness and also emergency response and preparedness work that will be important. So if anyone's interested in this type of work, feel free to reach out. There's certainly different things that we can do. I also want to emphasize, and in a second, I'm going to be talking about our CATCH, which is our Center for Advanced Technology and Communication. And there's a lot of crossover between the work which I mentioned and the PRI and that work as well. So I'm going to mention that in a second. But ultimately, here are the take-home points from what I just talked about. One is there's many complex factors that form complex systems that affect the spread and impact of infectious diseases like the COVID-19 coronavirus. And also, it's never one intervention. Vaccines alone are not enough. Face masks alone were not enough. Social distancing alone wasn't enough. Each of these different interventions need to work together within this complex system itself. And the impact and value is quite complex as well. You might have seen that image that's circulated on social media of the Swiss cheese, where each different types of intervention has its holes and its weaknesses. But when you combine the slices with holes in different places, that's when you get really effective response. And that's when you really see things shoot up in terms of effectiveness, or cases really shoot down. And one of the challenges that we've had throughout this pandemic is there's been too much of a focus on one thing at a time, where you really have to look at how should these things be combined. Testing is another thing that should be combined. And when I mentioned testing, Dennis Nash has been doing a lot of great work in that area. So how do we combine these different things? And these aren't new concepts, because we knew this back in 2009. It's just that from a communication standpoint, it just didn't get out there as well. And you saw many situations which decision makers were not really fully aware of that. And I feel that at CUNY SPH, we are uniquely positioned to really respond to help not just New York City, but the entire country and the entire world better respond to pandemics. We have a combination of the methodologies, the understandings of all these different processes, and the understandings of communities and social determinants of health to have a unique presence and footprint within this area, and a very large footprint at that. So with that, just wanted to give credit to our CATCH and PHICOR team. They've been doing great work throughout this pandemic, really incredibly dedicated. Their focus has always been, how do we help people? How do we help people, with our modeling work? Shout out to all of them, tremendous group of folks. And with CATCH, which again stands for Center for Advanced Technology and Communication and Health, we want to do both. We want to cross both, how do we apply computer modeling, AI, all of these new computer approaches to addressing different public health issues? And also, how do we communicate key health questions, key health information and issues to, the entire population, to a range of different stakeholders. And that includes using new techniques, like new multimedia techniques, social media approaches, and as well as computer approaches like simulation. So if anyone's interested in that, please feel free to reach out. We're gonna, we already have research activities, obviously, policy making, decision making opportunities, outreach opportunities. We're building up our educational opportunities as well. Even if you're completely new to the field, you don't have to know computers. Okay, maybe you need to know how to turn one on, but we can show you how to do that. That's pretty quick. You don't have to know technology. You don't have to know math. You don't have to be an expert in communications yet. You just have to have an interest in really understanding how things fit together, addressing complex problems, and be interested in communications. And there should be opportunities. So with that, certainly if you want to reach out, feel free to reach out by social media or visit the website or other possibilities. And again, wanted to thank the department, thank Dr. Eastwood for her leadership, and Dr. Terry Wong for his leadership of her department, and the opportunity to talk to you about all of this. I wanted to thank our esteemed dean for his leadership, as well as the opportunity to do this work and the funding. And thank all of you for all the great work that you all do, and happy to address any questions or go back to any of the slides with that, and open things up to the discussion.
Bruce, thank you so much for a really illuminating talk, and also the complexity of the interplay of systems. It's not just, your mathematical modeling kind of research, but your deep understanding of human behavior and being able to model that. One of the things I was struck by is, you're talking about the metaphor of the Swiss cheese. It's like that idea of the imperfection of each type of intervention as being imperfect in itself has been around for a really long time. And for whatever reasons, Americans choose to forget about it. So with that as sort of a segue into a couple questions I have for you about a little bit beyond your research, but your thoughts about it. And it's these. So one of the things that I'm sure that you've had access to is the pandemic plans that were put into place, or were shelved, I should say, were created and shelved in the Obama administration in pandemic preparedness. How much of your current and, let's say, future work may draw on some of those plans as you begin to draw up new plans, and also compelling arguments so that people pay more attention to what's obviously going to be happening in the world over the next several decades?
Yeah, excellent point, excellent question. The thing that we want to do is we don't want to reinvent the wheel, because in all areas of science, science builds upon itself. So there are many bright people that have been working, regardless of what area you're talking about or topic you're talking about. There tends to be layers and a history of bright people that have worked on, a problem. So you want to certainly leverage that past work and build upon it. So you don't want to just go back and say, okay, let's pretend we have a completely clean slate and not pay attention to what's been done before. And a lot of the pandemic response policy and guidelines that were in place was based on the work that we and other members of the Midas Network have been doing over years. So for instance, around, in the years between 2008 and 2010, there was the whole concept of targeted layered interventions, where we would layer different things and show the importance of layering those interventions. And those help people in BARDA and people in ASPR and people in the White House work those into the different plans. Now, we did have a disruption around 2017, where a lot of the veterans that we have been working with for many years segued out of the White House and other places like that. So there was some loss of institutional knowledge as a result. So part of this is okay, how do we take that, reclaim a lot of that, reinfuse that into plans going forward, and then further build upon that. We don't have to show again that multi-layers are important. That's something that's been shown many times. We don't have to show again the value of social distancing. That's been shown many times, even though over the past year, some people have questioned that. There's a lot of evidence that supports that. And face mask wearing is an example where there are other parts of the world where there was, people were wearing face masks. In fact, one of my PhD, actually, it might have been a DRPH, but I was her thesis advisor. She put together, for a thesis, she put together a study and a paper where she interviewed people of different, in Taiwan, Hong Kong, and the United States. And this is, again, around 2010. And she looked at their attitudes towards face mask use and all these different types of things. And they were starkly different because people in Taiwan and Hong Kong viewed face mask use as a way to help our neighbors, a way to help each other. And at the time, you got things like, she asked them like words like, okay, what words do you associate with face mask use? And he said, helping each other, cooperating, those types of things. And then you got words like affecting freedom, restrictive, that type of stuff when it came to people in the United States. So we already knew this way before, that this would be an example of a behavioral challenge. That if you were to roll out face masks, you're gonna get some people who will push back like that. So therefore you wanna do, before you do that, you want a message and you wanna come up with a plan. So I guess the short answer to your question is, yes, we definitely should use some of those plans that were in place before or established before, and then see how we can build upon them and adjust and adapt them.
I think there were a couple of questions in the chat.
So let me switch to the screen so I can see. When I can see I'll stop sharing and I'll look at the chat. Oops, my chat's not popping up for some reason.
Can you hear me?
Yes.
Yeah, I'll just read my question. Basically,
Okay.
Oh, thank you for the great talk. Very informative and exciting.
Thank you.
So my question is, have you modeled, based on the current situation, all the actions we're taking in the United States, when will everything go back to normal? I guess this is $1 million question.
Yeah,
and when will the world go back to normal?
Yep, yeah. That's literally and well, figuratively and literally the million or billion dollar question. One thing I actually didn't show in the slide presentation, and probably should have, is more recent work that we did with the New York Times. And that more recent work, that actually was published by the New York Times about a month and a half ago. And they were interested in better understanding what states, where states were in terms of vaccination coverage, as well as herd immunity thresholds, and how far different counties were from those thresholds, and which in turn would translate to how long would it be before we get to a point where enough of the population is protected. Mm-hmm. And essentially we found that, of all the counties in the United States, and of course throwing out some of the counties where we didn't have enough information, there were really only 5 counties that were anywhere close to the 80% or greater threshold that we're going to need to really interrupt the spread of the Delta variant. So as you probably know, the Delta variant is more transmissible, so that pushes up the herd immunity threshold that's needed. And so since the Delta variant has an R0 of somewhere between 5 and 8, that means that you need to get vaccination coverage in the 80s, not vaccination coverage, but I'm sorry, you have to get 80% or more people protected through a combination of either vaccination coverage and having natural immunity from having recovered from the virus. So we're still quite a distance from that. That was as of several weeks ago, and we're continuing to track that. So that being said, that suggests that really stopping the pandemic significantly before the end of 2021 is not likely. So it's not likely that unless there's a huge push to get a lot more people vaccinated before the end of 2021, this is going to move over into 2022, which is actually very consistent with what people were saying in 2020. So if you recall, there were many experts, including Anthony Fauci or Tony Fauci, that were saying that you're really looking at 2022 when things can return to normal. That's very consistent with what's happened in past pandemics. If you look at the 1918 pandemic, there was initially a herald wave in the spring of 1918. Then cases sort of went down, subsided during the summer. Then they picked up again fall of 2018. I'm sorry, not 2018, 1918. I jumped ahead by a century. 1918. And then the winter of 1918 and 1919 is when you had a big surge. Then it came down during the summer of 1919, and then the following fall and winter, it picked up again for the third wave. So that is a pattern that happened in 1918. There was a subsequent pandemic, I believe in either 68 or the earlier one, which mirrored that type of 3-curve bump again. So it's not surprising we're really seeing that with the COVID-19 pandemic. So that suggests that maybe spring of 2022, moving towards the summer 2022 is where we really can see an easing up. It may happen earlier if we can get vaccination coverages earlier, but that's the thinking right now. And again, you might have heard the term eradication, elimination. We're not going to eradicate the COVID-19 coronavirus. We're not going to eliminate that. In fact, as a society, we've eradicated very few viruses. We've eradicated very few viruses. There's guinea worm and smallpox, and we've eliminated things like measles from our country, but obviously not from the world. So that can't be the goal because that's unrealistic. The goal is to really push this COVID-19 coronavirus so that it becomes more of a seasonal virus. So it becomes more like the flu. So that means we need to get enough people exposed to this via, preferably through the vaccine, so that they have enough immune protection. So the next time the virus kind of goes around, it's more of a seasonal virus. Does that answer your question?
Yeah, absolutely. Thank you. Just one quick follow-up. What do you see based on your experience of all these pandemics or whatever? What things we're not doing enough or completely missing from the whole picture?
So one is the coordination with things. Things have been a bit haphazard. So all these things actually should connect with each other. Testing, face mask use, social distancing, vaccination, what you do in terms of schools and workplaces, treatments, all those should actually be coordinated. Because ideally what you want is testing helps you identify, gives you a line of sight. It helps you better understand where exactly this virus is spreading. And you can see in countries like Taiwan, they've done that very well. So they've really been able to track the virus very well. South Korea is not an example. And so they can quickly act. So you can quickly act to contain the virus and then do contact tracing and do that. And there wasn't enough of that coordination early on. And then knowing where the virus is most active and spreading the quickest can allow you to target those areas for vaccination. Of course, we want to vaccinate everyone or as many people as possible, but there's certain places where you can really focus on intensely getting people covered, or you can focus on channeling those resources in those places, or you can anticipate, okay, there's going to be a surge. Get ready in these emergency rooms, get ready in these hospitals. because the virus is not spreading like homogeneously. It's spreading in a pattern, but we've never really figured out that pattern very well. And the problem is we are chasing after the virus rather than getting ahead of the virus. So we're relying on things like reported cases, hospitalizations, and those types of things after the fact. And that means the virus has already been spreading in those areas for weeks. So we can't get ahead of those things. So we really should have integrated all these things so that they all work with each other. I can give many other examples of how these things work together, but I think that's been the biggest problem. That's one. Two is really preparing and planning prior to any types of changes. And so I mentioned the example of the vaccine. So there should have been plans before the vaccine rolled out, exactly how it's going to be distributed, who's going to get it and where, and those things. It turns out early on there weren't enough vaccination locations. People were like clamoring for the vaccine, so there just weren't enough. And the other thing is these plans need to be communicated. It would be like being a coach of a football team and saying, "Hey guys," or "Hey folks, we've got plans. We've got plans. Let's run out to the field. We've got plans. Don't worry." I mean, you want to tell the football team what the plans are before they run out onto the field. So the same thing, the football team in this case are all the people, all the decision makers, all the general public. And to not know the plans in advance makes it very difficult for the team, which is the general public and all the decision makers, to really cooperate because they don't know what the plan is. So I think communication has been a big problem. And then we're also not measuring all the right things. So it's not enough to just measure deaths and hospitalizations and those things. We really need to measure, and it's not enough to just measure, this is the total number of tests, this is the total number of people vaccinated. We really need to know who's getting vaccinated, who's getting tested, who's getting sick in different ways. This is why, this is a broader problem in healthcare where we don't have enough understanding about individuals and different groups, and especially disadvantaged communities, especially persons of color. We don't know enough of what's going on in different communities. And it's just, frankly, not only just unfair, but it's foolish. Because if we're going to try to control the virus, we need to know about what's happening everywhere, and everyone needs to be protected. So those are some of the things that come to mind.
Dear Bruce, this is Ayman. We have 8 minutes left, and on the chat, you have so many questions of people eager for answers. So one of them, it was asking you about where do you get your data to create your models. Another person was asking, what software or statistical programs do you use? Another one was asking, what are the limitations of systems modeling? So I'll put these three together because they're methodological.
Okay.
And I won't ask your question. So I'll use their questions instead.
Okay, thanks, Simon. Appreciate it. Yeah, for some reason, the chat box disappeared on my thing and I can't seem to recover it.
No worry. I'll do it for you.
It must be on one of the 4 screens that I have here. So. Yeah. Buried somewhere. So to answer that trio of questions, I'll answer the second question because it's the easiest to answer. Many times we develop our models from scratch. So we'll develop them in Python or other types of programming languages. But we've also developed models using, they've ranged from developing models in Excel to developing models in programs like Triage. We've used Vensim. We've used NetLogo, we've used all the different types of platforms. But ultimately, some models get to a point where they are too complex and they really basically outgrow the size of original software platform. So for instance, if you are interested in working with our center, many times what we'll do, and if you've never modeled before, we'll get you started on one of those commercial software packages. And then you can start modeling through that. Berkeley Madonna is another example that we can use as well. But then once you really start building some of these complex models, we start programming them from scratch. The first question is about the data. We draw data from many different sources. So when we're building our virtual populations, we'll use census data. We actually have a synthetic population that we've developed years ago that have been updating that basically combine all these different census files and locations of schools and locations of workplaces through business analysts and Yelp and Google. And we've created a representation of the entire United States population. So we use that for our US model and those things like that. And then for parameters such as the cost of different things, we'll use Medicaid and Medicare data as well as insurance data. We will use things like the Red Book, which has the drug cost data. When we're trying to figure out productivity losses, we'll use data from the BLS, the Bureau of Labor Statistics. And then when we're trying to determine things such as, of course, information on the pathogen, we'll pull from different studies to determine, what's the infectious period, what's the incubation period, what's the R naught. And then same thing with behavior. So we'll pull from available studies. Now, many times when we don't know the behavior, we will run sensitivity analyses to see what happens if you vary the behavior, because we know that behavior can be unpredictable in many ways. And the key is to develop recommendations and policies and interventions that will be robust to unexpected changes in behavior. So you never want to develop a policy intervention that's tailored to a specific behavior, because once that changes, then you might be lost. So hopefully that answers that trio of questions.
Bruce, I just have to ask this question, which is, if you had one or two things that you could say to the Biden administration about getting something done in the United States to ameliorate the problem of COVID-19, what would those one or two messages be?
So I think, one of the messages is what I mentioned before, that you really need to, there needs to be a clear strategy leading up to any type of changes. And that strategy has to include careful communications and those things. We saw last year that was many times an issue, and it continues to be an issue where you have to say, okay, when you make a certain policy change, you have to do all the things leading up to that, and you have to be prepared. And so the modeling is an example of something that can help prepare for that. You can run different types of game plans and different scenarios and see what might happen. And there are other things that you can prepare. We have this whole map or this diagram that shows how you map out the situation, you build a model of the situation, you run some test cases, you do some quick studies like cohort studies or what have you. That comes up with the plans, and it's an iterative process. So my recommendation is to use that iterative process to really move towards something, because we don't want to have a continuation where you have a change and then you have all these unintended consequences. We saw in the spring of 2020 when people were told, okay, if you're vaccinated, you can do these things. And suddenly, like, people vaccinated or unvaccinated, we're all relaxing precautions. So that was an example of an unintended consequence. So we want to avoid situations like that.
Thank you. I think we have time for like one or two more questions, quick questions. Let me see what we have here. Somebody wants to know how to begin working with Catch, get in touch with Bruce.
You can reach us in different ways. We have a Twitter account, so you can also try to message our Twitter account. You can contact our Director of Operations. You can send an email. There's different ways you can do that. So happy to connect with anyone.
Yeah. A couple of other questions also ask about how modelers can communicate their work to policymakers, and you've talked about that. Would anybody like to unmute and ask a last question before we close for today?
Oh, I know. I've been also mentioned another question which I neglected to address. So, what are the limitations of systems modeling? Well, of course, we see a whole range. Like, so just because something's a systems model, it can range in quality and how it's used and those things like that. So, just as with any type of methodology or tool in itself, can vary significantly. So the key things to keep in mind is, one is every model that's developed, whoever develops a model has to be clear about these are the strengths and these are the limitations. So we've seen examples of models being used where there's a tendency to say, okay, this is the magic model, let's use it for everything. And that's not the case. So, like, in 2020, the White House frequently mentioned the IHME model. That was actually a top-down statistical model where they looked at trends before and then they extrapolated those trends. And that was useful, again, from a top-down standpoint. But that will have limitations in terms of it doesn't really show cost effect and you can't really test different types of interventions. But that wasn't really broadcast by some of the decision makers that were using that. So it's really important to say, okay, but here are the limitations of that. And it's important to use different models. So each of the models in itself have their strengths and limitations. So it's harder to broadly say that, here are the limitations. That will be like saying, here are the limitations of a clinical trial, because we know that clinical trials can vary significantly in different ways. It's actually how you actually put it together and run it.
Thank you. I think we're about the hour now. If people have additional questions, they can contact Bruce and his team. I want to thank you again, Dr. Lee, for an excellent presentation, for everybody else joining us here today. And we look forward to continuing to read your fine work. Thank you.
Thank you, everyone.
Thank you. Thank you.